As we've learned, medication is important, but it has modest potential to be helpful to people who live with chronic pain. Having said that, it's a very challenging area of clinical practice, and the communication challenge around opioids, benzodiazepines, sedative hypnotics, cannabinoids, and the like challenges, I think, even the most skilled communicators. Having said that, when this file was handed over to me 4 years ago, my predecessors very seriously said, Galt, what you'll find is that struggling with this area of practice is a marker for a more generally deficient practice skill set. And that's the point at which I looked at my shoe tops, because I struggled with it, and I do find it inherently difficult. As David said this morning, this is an area where family physicians are at the center of it. One of my jobs is to field hundreds and hundreds of advice calls, catastrophizing panic calls from doctors. It's one of the reasons I went to work at the college, because I used to get so many of those calls in my clinical office. And this is an area, and of course the usual request is, after we get past, can I fire this patient? Where can I send this patient? And it's really an exercise in affirmation. There's no one better than the person with deep knowledge of the individual, who knows what makes them tick, what they aspire to, what they value. That person is the specialist best placed to manage the care of that patient, and that's the family doctor. We begin again with the patient. And we've been told that roughly 20% of Canadians live with chronic pain. Opioids are important, but patients are disappointed by the extent to which opioids are the beginning and the end of what we think we have to offer them. Many of you might have read this book. This is someone who went from being an academic, suffering life-threatening injuries, and being incapacitated by chronic pain. Chronic pain is isolating, and she's looking for her physician to help address that isolation and coach, just as we've heard. The college is engaged. I've been told, why don't we fuss about beta blockers like we do about opioids and benzodiazepines, and it's because of risk. This year, 70 British Columbians will die as a result of drinking and driving, but about twice that many as a result of prescription drug misuse. Quadrupling of opioids in the U.S. Has been accompanied. Association does not prove cause and effect, but it's a tight association between the rate of death and addiction. Why does this happen? Cute, eh? It's one of my grandchildren. And that, even if you don't know him, he's cute. Where does that come from? Every thought, every feeling, every human action is chemically mediated, and this is our challenge. Controlled drugs, everything that's potentially addictive, feeds into the same reward system that all the things that are important in life are. That impulse to care for a child, to get nutritious food, to procreate, to bond with our families, it's inevitably the same chemical system that opioids, benzodiazepines, cannabinoids, and the rest also interfere with. And Jane Ballantyne puts it this way. She says, when we prescribe these drugs, we are commandeering the neurochemical system that essentially gives meaning to human life. And that's not something we should take lightly. So what about the college? I'm here to tell you that the prescribing concern about the college is on the quality assurance side of the organization. It's private, it's privileged, it's educational, it's collegial. We are benign, respectful, kind, and friendly people. I mean, who wouldn't want to correspond with the people in this picture? If you get a letter from us, it's because we want to have a conversation. And as I say, we don't have the authority within reason to insist on anything more than you engage in the process. And with that, I want to leave you, or use the last few minutes, with 8 principles, 15, excellent, 8 principles that in the long experience of the prescription review program of the college, based on the clinical experience of the doctors, our interpretation of literature, and maybe more particularly the privilege of working with hundreds of BC doctors to improve this area of their practice. This is what we'd like you to focus on. And the first is a value that certainly the people in this room who are self-selected, I'm sure, share, and that is that people who live with chronic pain need primary care physicians for all the reasons you heard all morning and for the first hour of this afternoon. Chronic pain is isolating. This is a condition that people live with, and they deserve and need primary care. So don't turn them away. Well, what about the people who show up, and these are the ones that generate the phone calls to me, with a consultation, a note from a previous doctor, or a firm conviction on their part that prescribing a mix of medications that you're not comfortable with is the only thing that works for them, and they're stable on that. Well, one of the spin-offs from an area of scientific controversy and a paucity of empirical data is the privilege, or at least the privilege and the responsibility to be responsible for your own prescribing decisions, and be clear about that with patients. Other doctors may have made other decisions based on the same information. I have to make my decision in this challenging area of practice. Now, having said that, the first day you meet that patient, you don't have all that data. And so what you also owe that patient is a comprehensive initial and assessment and ongoing reassessment. In other words, the practice of medicine as you know it and do it so well. We've heard about nociceptive and neuropathic pain, various contexts. From the college perspective, at a very foundational level, be deliberate about distinguishing between 3 contexts: acute, end-of-life care, and chronic non-cancer pain. We've heard, and it's only logical, that people with chronic pain began with acute pain. And the challenge we see over and over again for doctors is that they sleepwalked from one stage to the other without really giving that transition enough consideration. Number 4, patient selection is important, but as I was saying this morning about the opioid risk tool, low-risk people can also get into difficulty. But as you've heard, if the patient suffers from the lifelong disease of addiction, if they have a significant mental illness, if they're under the age of 40, the opioid manager says if they're between 16 and 45, if they suffer from fibromyalgia, irritable bowel syndrome, chronic fatigue syndrome, and so on, these are patients that are at risk and you need to take care with. Having said that, there is emerging evidence and certainly expert concern that we be aware of the fact that everyone is at risk of addiction for the reasons I was pointing out with that reward system that's evolved over a million years. Finally, while I do agree with David's comment this morning that depression is depression and needs to be diagnosed and treated, not all human emotions are pathological. This is just one article, an opinion piece by a man whose son died as a result of drug addiction, and his grieving met DSM criteria for pathological grieving, and he was questioning whether medicalizing an intense but normal human sentiment is helpful to anybody. The point here is that those observational studies that Patrick was referring to about who ends up on opioids, who ends up taking a lot of medication for a long time, are giving us a consistent message, and that is, it's the people with broken hearts. And certainly the doctors that I've communicated with, sure, we can't confidently identify a biomedical pain generator. Sure, it's not working. Sure, the patient's been to emergency 3 times with overdoses, but you don't know what she's been through. sexually abused as a child, married to an alcoholic, the child of an alcoholic home, a child of hers hit by a car and killed, and so on. Those are the people who disproportionately end up on opioids and benzodiazepines. And we do it out of compassion and caring, but it's a common error that we see. We're up to number 5. Patrick alluded to this. We have so many randomized, controlled, prospective trials ranging from 1 to 16 weeks, averaging 5 weeks. Andrea Ferland's meta-analysis of 2006 had over 40. We're up to about 68 now. They all say the same thing. Opioids are better than placebo. They have the potential to afford modest improvement in symptoms. Functional improvement is harder to prove. Strong opioids are more likely to improve the intensity of pain, but less likely to improve function, and so on. Addiction has never been systematically studied, and the dose, on average in these studies, was between 60 and 85 morphine equivalent daily. So when we talk about a watchful dose of 200, we're already in a range that has not been systematically studied. Number 6, it's simple. The college obsession is with dose and dispense, but mostly with combinations. You saw the study, the review of coroner's cases that the medical health officers in Interior Health did. They looked at 5 years of coroner's reports and looked for a profile of people who died while on prescription opioids in that part of British Columbia. And they found that the majority 85% were working full time, only 20% were on more than the equivalent of 20 milligrams of morphine, but virtually all of them, 93%, were on a combination of an opioid with another sedative, usually a benzodiazepine. The other thing is alcohol, and my suggestion for people in family practice is that you need some hard endpoints to backstop. So tell patients explicitly, if you're going to get an opioid, you must not drink, not even one drink. And we talk to doctors, does this patient drink? Not very much. Have you asked? Well, not really. That's something that we mustn't make assumptions about. The other thing is that all the guidelines say taper and discontinue benzodiazepines if possible. And, you know, we never say never in medicine, but I think it's fair to tell patients, I'm weak, I have trouble saying no to patients, and so I had to fall back on one of those hard endpoints, which was, I would say to my patients, there's a rule. If you take an opioid, you can't take a sleeping pill, and if you take a sleeping pill, you can't take an opioid, and I'd commend that to you. It is okay. Doctors will phone me and say, look, my patient is taking all this opioid, and they're spectacularly sedentary. They won't get off the couch. They won't moderate their smoking or alcohol. Is there anything I can do? And based on everything you've heard today, there is absolutely something you can do. It's to give them an evidence-based advice that this medication is not helpful enough to be appropriate if you won't move, if you won't go to bed at the same time every night and get up at the same time every morning and put clothes on, all those important lifestyle considerations. And finally, the universal precautions for safety. Pharmanet in British Columbia is a standard of care in all episodic points of care. So walk-in clinics in emergency, some doctors don't know, but every time you write a controlled drug prescription for a patient you don't know, you are required to consult Pharmanet. Talk to your EMR provider. Treatment agreements, random urine drug screens, those have been commented on by others. To learn more, there are just so many resources now. The academic detailing, get it. We have a prescriber's course if you want to practice the scripts that you heard. It's one day, it's powerful CME, 4 standardized patients, and a supportive environment with benign people like me. If you want to bend somebody's ear, certainly the consultant on the phone, you can also call us. So, 8 points. Don't turn patients away. Your prescribing is your responsibility. Be clear about where you're at. Patient selection is important. Realistic expectations communicated clearly. Dose, dispense, prohibition on combinations. Make prescribing contingent on things that are actually helpful. And review PharmaNet every time you prescribe. And if you develop an approach, you'll have a more gratifying professional life and fewer encounters like Keith White #2. Thanks for your attention.